Welcome to Southwestern Human Services Fraud, Waste, and Abuse Documentation and Utilization Training. The agenda for today's training is to review Southwestern's policy for fraud, waste, and abuse, our quality assurance satisfaction surveys that we use in order to ensure that fraud, waste, and abuse is not occurring, the definitions of fraud, waste, and abuse, as well as examples. We'll review how to complete your documentation accurately to avoid fraud, waste, abuse. We'll review utilization and answer any questions that you have. Southwestern Human Services has established procedures to prevent and detect fraud, waste, and abuse that comply with regulations set forth by the Office of Inspector General of the Department of Health and Human Services and with the requirements of the Bureau of Program Integrity of the Department of Public Welfare. Practices also comply with regulations established by Health Choices managed care organizations. Southwestern is committed to ongoing training of employees to educate and attempt to control fraud, waste, and abuse. In circumstances where fraud has been established, Southwestern will take all necessary actions required, along with local, state, and/or federal agencies to address the actions of the perpetrator of fraud. All policies, procedures, and regulatory materials are available for review in the BHRS department. The definition of fraud is the intentional deception or misrepresentation made by a person with the knowledge that the deception could result in some unauthorized benefit. This includes any act that constitutes fraud under applicable federal or state law, knowingly or intentionally submitting false claims. The following are examples of fraud. To purposefully bill for services that were not provided. So if you go to a family's home and you have them sign an encounter form for a date and a time that you did not provide services, this is considered fraud. The rounding up of time, you have to put on your encounter forms the actual clock time that you were working with a client. Willfully falsifying the content of any part of a progress note, encounter form, or treatment plan to include dates, times, place, type of service, persons present, content of the note, etc. Forging a signature of the parent, guardian, caregiver. This also extends to school personnel, daycare, staff, anyone who needs to sign the encounter form. If you forge their signature, that's considered fraud. Falsifying your credentials, billing for program material that you did not create. This extends to BSCs or lead clinician MTs. You cannot bill for printing things off the internet or using somebody else's materials and passing them off as your own. Billing for the same program material for more than one client is fraudulent. Overlapping services. So if you have an overlap where you say you were with one child and another child at the same time, that can be misconstrued as fraud. Services not performed by the billing provider, a signature stamp used on progress notes, and falsifying timesheets are all examples of fraud. Waste is the thoughtless or careless expenditure, consumption, mismanagement, use or squandering of healthcare resources, including incurring costs because of inefficient or ineffective practices, systems, or controls. The overutilization of services or other practices that result in unnecessary costs. The following are examples of waste. Being inefficient in the methods of how treatment is delivered, inadequate collaboration between child serving systems that result in a child's extending services, submitting incomplete and/or inaccurate paperwork, using interventions that are proven to be ineffective. We only use evidence-based interventions. Otherwise, you're utilizing interventions that are not proven to work, which is a waste of the child's prescription and a waste of services. Failure to establish target dates for completion, failure to organize treatment to achieve expected outcomes, providing services at a subclinical level, and a misuse of resources. We talk about a lot of these further on in the training where we give specific examples of how this applies to cases. The definition of abuse are provider practices that are inconsistent with sound fiscal, business, or medical practices and result in an unnecessary cost to the Medicaid program or in reimbursement for services that are not medically necessary or that fail to meet professionally recognized standards for health care. It also includes recipient practices that result in unnecessary costs to the Medicaid program. Examples of abuse are as follows. Billing for non-covered services. Billing for services by mistake. attempting to obtain services where medical necessity has not been established, poor utilization of services while attempting to extend services, using services to supplant the parent caregiver's responsibilities, misusing staff's time, and creating unneeded overtime. The history of program integrity reviews the laws at the federal and state levels that were created in order to try to prevent fraud, waste, and abuse. The Federal False Claims Act states that anyone who commits fraud is liable for a civil penalty of not less than $5,000 and no more than $10,000 plus 3 times the amount of damages for those who submit or cause another to submit false claims. The other laws that are applicable are the False Claims Whistleblower Employee Protection Act, the Stark Law, the HIPAA Law, and administrative remedies for false claims and statements. The regulatory changes that occurred to continue to develop the prevention of fraud, waste, and abuse are the Fraud Enforcement and Recovery Act of 2009, which amends the FCA intent requirement and says that a false statement need only be material to a false claim in order to be accused of fraud. The FCA now prohibits knowingly submitting a claim for payment known to be false or fraudulent, making or using a false record material to a false claim or to an obligation to pay money to the government, engaging in a conspiracy to defraud by the improper submission of a false claim, or concealing, improperly avoiding, or decreasing an obligation to pay money to the government. There's also the Patient Protection and Affordable Care Act, which expands audits and government programs and requires providers to return overpayments within 60 days of identification. It increases sentencing guidelines for healthcare fraud, makes obstructing a fraud investigation a crime, and makes it easier for the government to recapture funds. It enhances provider screening and enrollment requirements, and it increases funding to prevent, identify, and fight fraud by $350 million over the next 10 years. It's important to remember that all providers will be audited. So Southwestern is a provider, and you as a BSC, TSS, or MT are also a provider of services. So not only are we audited as a provider on our policies and procedures, but you as a TSS, BSC, or MT are also audited to ensure that you're following appropriate service descriptions and completing your documentation accurately. We run audits constantly here at Southwestern. We're always reviewing notes and reviewing charts. So I can't stress enough to say that everyone is audited here at the agency. So it's critical that you follow, again, all policies and procedures. The current audit activities at the federal and state level are the Program of Bureau Integrity, which was created to ensure, among other things, that the Pennsylvania Medical Assistance Program is protected from provider fraud, abuse, and waste, and that medical assistance recipients receive quality medical services. BPI audits can be conducted at random or based on complaints, referrals, and tips. All providers are at risk. BPI will review records, conduct interviews, and make on-site visits to determine if services violate medical assistance regulations. Serious sanctions can be imposed upon providers who fail to meet state and federal regulatory guidelines. A compliance audit is a comprehensive review of an organization's adherence to contractual and regulatory guidelines to evaluate the strength and thoroughness of its compliance preparations. Auditors review policies and procedures, internal controls, and risk management procedures over the course of an audit. Other current audit activities through either the state or federal level is a program integrity audit, which is a comprehensive review of an organization's adherence to contractual and regulatory guidelines to evaluate the strength and thoroughness of its efforts to prevent, detect, and correct fraud and abuse. A claims billing audit is a review of medical records and other relevant documents to determine whether the documentation supports payment of a claim for services. Federal level activities include Medicaid program integrity. It's the first federal strategy to prevent and reduce fraud, waste, and abuse. They hire contractors to review Medicaid provider activities, audit the claims, identify overpayments, and educate providers on how to prevent fraud, waste, and abuse. Provide support and assistance to states in efforts to combat Medicaid fraud, waste, and abuse. There's also the Medicaid Integrity Group, who's responsible for implementing the MIP, and the Medicaid integrity contractors, who are regional contractors hired through the MIP to ensure paid claims were properly documented, billed properly using correct and appropriate codes for covered services, and paid according to federal, state, and laws, regulations, and policies. If fraud is confirmed, immediate termination and legal action, including criminal prosecution by the Pennsylvania Office of the Inspector General, can occur. Under the Federal False Claims Act, if a person knowingly submits a false claim and knowingly makes a false record or statement to have a false claim paid by a federally funded healthcare program, that person is subject to civil penalties. The person is liable for up to triple damages and penalties between $5,500 and $11,000 for each false claim that's knowingly submitted. In addition to civil penalties, individuals can also be excluded from participating in any federal healthcare program for noncompliance. That means you as a TSS, BSC, or a mobile therapist, if you submit a claim that's not true, that's fraudulent, you could be subject to these penalties, not just being fired from our agency, but you could be investigated by the Office of the Inspector General, the Community Care Health Organization, who's the insurance company that we work with. And not only would you have to pay back the claims, but again, you'd be liable for triple damages and the penalties. Also, you could be subject to not being able to bill under a Medicaid healthcare program again, so you would not be able to work in this field. How to recognize fraud, waste, and abuse. Fraud, waste, and abuse can come in a lot of different forms within our services. So there's different ways that we look for if fraud, waste, and abuse is occurring. And at Southwestern, we constantly are looking for certain indicators that could, say a person is committing fraud, especially by reviewing notes, completing audits, looking at how things are billed for, making sure that people aren't overlapping, etc. Some of the common fraudulent activities are billing for services that are not provided, so billing for time when the member is not present, extending sessions and having parents sign when you did not provide the service, or having a parent sign a blank encounter form. Using false credentials, signing off as having certification when the credentials were expired or revoked. Double billing, getting paid the maximum allowable amount for the same service by two different funders. Billing for phantom patients, billing for members that do not exist. Co-payment evasion, providing false information, and the sharing or theft of medical benefits. Those last ones really apply more to the fiscal department or to people who are billing out for services. But the first ones, billing for services not provided, is the most important one that applies to field staff. Misrepresenting the diagnosis to justify the service, so exaggerating symptoms to obtain more services. That's considered a waste of services and fraudulent as well, because you would be saying that the child meets a medical need for the service that they actually don't. Misrepresenting the type or service, the type or place of service, or who rendered the service. So stating that the service was performed in the home when it was actually provided in the member school is fraudulent. Billing for non-covered services. So as a BSC, if you were billing for printing information off of the internet, that's not a covered service and that's fraud. Inappropriate documentation for services billed. So if your note is too short, you don't state what you did during the session, that's all a waste of service, and it could be considered fraud if you're billing for services and not actually providing the appropriate level of services. Or upcoding, which is billing for outpatient individual services instead of outpatient group services, which doesn't apply to BHRS at this point in time. Delays in discharges, so saying that a client continues to need the service when they don't and they should be discharged, is fraudulent. Duplicate documentation for separately billed services, so if you copy the same note for one member for a different member, that is fraudulent. You have to write a unique note for each separate session and separate client that you do. Forgery is fraudulent, so if you have staff or other members of the treatment team signing encounter forms for another person, or yourself, if you sign somebody else's name, that's forgery and fraud. Failure to collect coinsurance, failure to resolve overpayments and kickbacks. which again apply more to the billing department than BHRS at this point in time. Unexplained entries of altered records, unauthorized transitions, missing approval signatures, discrepancies in handwriting. We actually found someone who was forging parent signatures by comparing the signatures of the parent on the intake with the signatures on the encounter form. So we do compare, we do look for that. Lack of or out of date written policies and procedures, missing files, reports, data, and invoices, missing weak or inadequate controls, and inadequate monitoring by management. These are all important things when looking at fraud, waste, and abuse. Again, they might not specifically apply to field staff, but it's important for you to know that Southwestern has policies and procedures safeguarding us against fraud, waste, and abuse, and we look at all of these items and take them into consideration with how we run our programs and our billing systems. It's important to know that whenever you're documenting your services, you have to document services as they happen during that session. So you have to put in what you worked on, what interventions you used, what worked, what didn't work, the goals that you worked on, because documentation is critical whenever we're looking at fraud, waste, and abuse, and these are legal documents that need to be taken very seriously. So we always tell people if it's not documented, it didn't happen. So you have to make sure to accurately document everything that you're doing with your clients. We're going to go over basic documentation requirements because whenever we're looking for fraud, waste, and abuse and preventing it, it's critical that we review documentation to ensure that it meets regulatory standards. And if it doesn't, then we take appropriate corrective action to ensure that our staff are completing their paperwork as they need to. So all staff are required to know Southwestern's documentation policy and procedures. This is reviewed at orientation, but we are going to review it now at this point as well. The critical issues include start and stop times have to be accurate and on your encounter form and your progress notes. Service codes have to be on your encounter forms and progress notes and must match and be accurate to where you provided the service. Individualized progress notes are required for each client. Notes must be specific to the member, appropriately support the time and type of service, and tie back to the treatment plans. The member's name must be included on all notes. Progress notes have to have enough information to justify the length of time that you were there for the session. If you're having a 3-hour session, simply writing a sentence or two does not support the time that was billed. This could be considered fraudulent. So whenever you're writing your notes, make sure to include all information that happened during that session. All entries are to be written in black ink or typed, no pencil and no whiteout. The units billed must match the number of units on the documentation. A full signature with credentials and dates must be on all the pages that are submitted for that child. Covered versus non-covered services means that are the services documented covered services according to BHRS? So if you're a TSS, if you are providing babysitting service, that is not a service that's covered and it's not billable, and if you try to bill for it, that would be considered fraud. Service definitions. Are the services provided and documented? Do they meet the service definition for the code billed? So if you're providing a TSS service, but you're saying that you're doing observation, that's actually a BSC billable function. So your service provided does not match the code billed. Same thing with a BSC. If you are doing one-on-one therapy with the child as a BSC and you are not conducting an assessment, that's more of a TSS service, and then your service definition or your documentation would not match the service that was billed for, which is fraudulent. Your progress notes must be legible, and amendments to any notes must be initialed and dated with single strike lines through the change documentation. This is critical whenever you're making any changes to your notes. Don't just scratch things out. You have to put one single strike line and initial it. Again, these are legal documents that go into a child's record and are used to bill for medical assistance services, so it's critical that you follow these guidelines. All documentation billed for must be available for review in a member's chart. So as a BSc or an MT lead clinician, if you're creating programming materials for that child, you have to attach them to your notes so that they can be available for review under audit. If they're not available for review, you would be required to pay back the amount that we paid you for that service. Documentation must include all required elements, which includes DAP format for BSCs, measurable objectives for all service providers, place of service, persons present, etc. Pretty much all places on the note must be filled out in its entirety. Provider signatures must be present and legible on progress notes as well as credentials. Services must be provided according to the requirements, and all errors must be corrected in the required manner. The progress note must indicate the progress at each visit, the change in treatment if there were any, and the child's response to treatment. So you want to note if the child responded well to the treatment interventions or if they did not respond well, and evidence to suggest why you think that did or did not happen. You must include the relationship of the services to the treatment plan, so you have to have a measurable objective on every progress note, and within your note you have to document if the child, like where they're at in relationship to that objective. So if the objective is to reduce aggression, you want to say how many times they had aggression during the session, what interventions you used to eliminate aggression, what replacement skills you reinforced to replace the aggression, things like that. State the specific intervention that was provided to the member, and then review the plan for follow-up. Your plan for follow-up should never be just to meet with the client or to work on interventions. It should be something specific for that child's treatment. So again, if you're working on reducing aggression, your plan for the next session is going to be to continue to see if a coping skill is a good replacement skill for the aggression. Again, it has to be something specific that's related to the session that you just completed. Progress notes that consist of mere observations do not meet regulatory requirements. Therefore, those sessions would not be considered reimbursable sessions. Any member who's providing treatment cannot just say that they observed a child during that session. You have to be monitoring treatment, assessing treatment, making changes to treatment, or implementing treatment. Again, if you just write observations, that's not considered a billable service, and we would have to pay that back under audit, which again would then fall on you to pay back under audit. What we wanted to do was provide CCBHO's auditing checklist for all of our staff, so they know what the insurance company is looking for within documentation, and as well as what we are looking for. Documentation is important not just because it has to meet insurance company standards, but because it has to be a good record of the child's treatment, and we have to ensure that the child is receiving the best treatment they possibly can. So some of the things that we look for and the insurance company looks for is any missing documentation. So if we billed out for a service but we can't provide the documentation to support that claim, that's a very serious issue. We would have to pay that claim back. They look for that if we billed for services that were not rendered, documentation supports fewer units than billed units, which again goes back to you have to put sufficient information in your progress note to justify the time that we billed. So remember that if you have like a 2 or 3 hour session, you have to be working on multiple objectives. That has to be documented in your progress note, and you have to put in more than just a few sentences. You really have to put in a good amount of information to talk about what you did during that entire session, or we would have to pay back that amount of services because it would be considered fraud. They look for any overlapping services that occurred. Billing for non-billable services. So again, if a TSS is babysitting or if a BSC is billing for doing one-on-one work, that's all a non-billable service. They look for that there's no breaks in time from one venue. They look to see if there are no breaks in time from one venue or member to another. There has to be a 5-minute gap in services from one member to another, or when you're traveling from one venue to another. You can't start and stop a child at the exact same time. That's considered an overlap and fraud, because you can't technically be working with the same child at the same time. And then again, documentation does not support the submitted claim. They also look to see if there are no treatment plans present in the child's record. which treatment plans are critical. They're the guide for treatment, so they have to be available in the child's chart at all times. The TSS, Mobile Therapist BSC, should always have a copy of the child's treatment plan, as well as the family, the school, the daycare, whoever else is part of that child's team must have a copy of the treatment plan. Billing for travel time when prohibited. We have specific requirements for travel time, and if you have questions about that, please see the clinical administrator or the HR department. They look for a signature stamp on progress notes, which you cannot have. You have to have an original signature. They look for a consent to treatment in each client's record to say that the parent did consent to their child receiving treatment. They have to ensure that a treatment plan is signed by the member. If a child's 14 or over, they have to sign all of their paperwork. Otherwise, the parent has to sign that they're in agreement with the treatment plan and that they're in agreement to follow through with the interventions laid out in the treatment plan. The insurance company looks for identical or nearly identical treatment plans. And if they are identical or nearly identical, we have to pay back the money that was billed for that, and it's also considered a waste of services. Treatment plans are developed to be used within a 6-month period, so they should always be changing to meet the client's needs. The objectives should be changing, or if they're not making progress with their objectives, that would indicate that the interventions need to change, so then that would be changing as well. They look for identical and nearly identical progress notes, and this is one thing that we look very closely at too. You can't even have a nearly identical progress note. That is considered fraud. Again, I said previously, every single note has to be unique to the member in that treatment session, so it can't even be nearly identical. I can't stress that enough. It has to be a totally different note. And they also look to make sure that there's AMs and PMs listed on the encounter forms and the progress notes. Utilization issues occur that prevent a child from getting services at the prescribed level or services being utilized appropriately. If parents don't understand what BHRS is or what the treatment plan states or their role within treatment, they might not be utilizing interventions in the absence of the team. They could be inadvertently reinforcing inappropriate behaviors and not reinforcing appropriate behaviors, and thus, treatment is ineffective. So we have to have an appropriate plan in place to address that. There could be insufficient support or collaborative efforts. So if we're in a school and we're trying to get the teacher to utilize interventions, if she's not interested in that or doesn't want to participate, then it's a waste of the services in school. Barriers to treatment within the member caretaker provider environment can exist that are a utilization issue. So if there's no TSS or the prescription is not being done at the full level because of the child's illness, those are all barriers, and we have to have a contingency plan in place to address those barriers in order for the child to get the service at the prescribed level. There could also be cultural competency issues, or the service fails to be flexible. Other utilization issues that occur that impact the ability for services to be effective include that the service fails to be child-centered and family-focused, which are part of the CASP principles, which the service is built on. Therapeutic boundary issues. So if you end up talking to the parent all day about your wedding, or they talk to you about their poor marriage or something like that, those are all boundaries that shouldn't be crossed with the family. You should always be very clinical and keep the conversation centered around treatment. So it's very important that you do not cross boundaries with families. You can be under prescription, therefore extending the length of services. If there's frequent cancellations, that means that the child isn't getting their prescription, and we would have to address that because then services would again be extended. Dissatisfaction with services. If a parent isn't happy with their staff, with the way services are going, we find that they'll start canceling a lot or won't participate in the services appropriately. If there's no commitment to services, this is a very intensive service, so if the parent doesn't really have the time to commit, or it just doesn't want to invest the energy into services, then we're going to have a utilization issue. If the member's enrolled in the wrong service, so the service is too intensive or not intensive enough, that's a waste of this service, and it'd be important for us to get them into the correct service. Dissatisfaction with staff, which I referenced earlier. any scheduling issues that occur. So if you're a TSS and you can only do certain days, but the parent keeps trying to change it, excuse me, and we end up not being able to get the full prescription in, we would have to have a plan in place to address that utilization issue. And a low confidence level in the service's ability to reach expected outcomes. We definitely have parents who will say, I don't think this service works, but we always want to ensure them that this service is proven to work. There's scientific evidence to suggest that behavior modification therapy works, and we only use evidence-based strategies, which again are scientifically proven to work. So we can provide some psychoeducational information for parents if this is one of their concerns. So what can you do to prevent fraud, waste, and abuse? In order to prevent it, make sure that your documentation and your clinical processes are accurate and complete, and that you're following our policies and procedures for services. If you suspect fraud, waste, or abuse, you can contact your supervisor immediately. You can also talk to our program director or our executive director. If you don't feel like the situation is being remediated, you can call the Fraud, Waste, and Abuse hotline or submit a formal complaint at the address that's on this slide. If you have any questions about the content of this training, please see the HR department, the clinical administrator, or the program director. We reviewed a lot of concepts for what fraud, waste, and abuse is, how it occurs within our services, and how to prevent it. We also reviewed a lot of situations that come up that can lead to waste and abuse of services, but really the best way to ensure that that doesn't occur is to ask the office or the lead clinician on the team to help devise a plan to overcome any barriers that occur. We didn't review all of those here in this training just for time's sake, but that can always be reviewed on an individual basis and on an ongoing basis. So again, if you have any questions, please review this with the administrative staff, and we'll be glad to help.